Within the next 2 decades, 1 in every 5 Americans will be over the age of 65. Physicians face unique challenges while treating elderly patients who often suffer from multiple chronic diseases, lower health literacy rates, and difficulty paying for their care on a fixed income.
There needs to be a proper emphasis on geriatrics in training.
That's Dr. Paul H. Wick. Dr. Wick is the immediate past chair of the AMA Senior Physicians Section. He recently served as the medical director for the University of Texas Health Northeast Senior Behavioral Health Outpatient Counseling Center. On this episode of Moving Medicine, a podcast from the American Medical Association, Dr. Wick discusses health issues and disparities unique to elderly populations. I'm your host, Todd Unger, Chief Experience Officer at the American Medical Association. This episode of Moving Medicine is one of 3 parts about improving health outcomes for vulnerable patient populations. The speech was presented at the 2018 AMA Annual Meeting in Chicago. Here's Dr. Paul H. Wick.
The poet Robert Browning wrote this: "Grow old along with me, the best is yet to be, the last of life for which the first was made." That's ideal, but unfortunately there's a segment of the elderly that, because of some disparities and some problems, that it's not a good situation. We have a growing population of older adults. 1 in 7 Americans currently are 65 years and above, and in another 15 to 20 years, it will be 1 in 5 Americans are 65 and above. We have an aging population. Currently, there are 46 million people that are 65 and above. That will grow to 73 million in the next 15 years and will double to about 90 million in 30 years. And it also accounts, the care of these 65 and above accounts for about 2/3 of the U.S. healthcare budget. We have a baby boomer population that's growing. There are currently those that are 54 to 72 are coming on, and those will add to the population of the older adults. It's said that this population accounts for about 27% of doctor visits and 35% of hospital stays. There are challenges to care for the elderly population and to promote good health. This is in spite of universal coverage for Medicare people. And older adults are not isolated from other health disparities. 2/3 have 2 or more chronic medical conditions. And so, that leads to the cost of care and the cost of treatment. Some elderly on fixed income cannot afford the care, and so therefore they cut back, unfortunately, and have adverse health consequences of that. Their chronic disease may cause negative health consequences in mobility and activities of daily living. And we know that the number with dementia will continue to rise with the population. So what are healthcare disparities that affect the elderly? Well, to list these, one are the issues that the ethnic and racial minorities may have. Then there's the social factors, the economic problems, educational problems, and even geography. The LGBTQ community, when elderly, have their special problems. Healthcare literacy and communication is also a problem and a factor. Ageism, the concept of ageism. Mental health issues and cognitive issues affecting the elderly. And we'll go into these each. The National Institute of Health defined health disparities as the difference in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the U.S. The term health inequalities more often refers to those socioeconomic differences. But for the purpose of my talk, these all run together. Regardless of your culture, your ethnic status, all of these other factors, the socioeconomic factors, the literacy, communication, they all sort of blend together. So it's often hard to say that it's all due to one factor. So we have an increasingly diverse ethnic and racial minority population, and this will grow in America. And minority elders are expected to account for some 50% of elderly in the next 25 to 30 years. And they may suffer a disproportionate burden of illness and early death, may have greater rates of diabetes and cardiovascular disease. And so this affects their health, but also their family that may be disadvantaged by this, and also the community that they live in by the lack of improvement in their health status. They may have different attitudes about health care. They may come from a culture that has certain taboos and attitudes about what is disease, what causes disease, what is the treatment, what are the providers. The Robert Wood Johnson Foundation states that these disparities in healthcare are said to cost $6 billion per year. So the socioeconomic factors that studies have confirmed that lower educational and lower economic status adversely affects one's health. Conversely, higher education and higher family income more likely is associated with being healthy. Older, non-Hispanic white adults are more likely to report being healthy. Where you live affects your health. In my area, which is a smaller metropolitan area, if you go to each of the surrounding counties, the longevity on average drops 10 years. So where you live, and it may be affected a lot more in certain communities. The older LGBT community have higher levels of illness, disability, and premature death. About 50% report a disability, and a third report depression. More than 20% do not disclose their sexual or gender identity to their physician. So, health literacy and communication matters a lot. This is defined as the capacity to obtain, process, understand basic health information and services, and make decisions accordingly based on that. Those that are 65 and above have a smallest percentage of health literacy skills. Baby boomers are more likely to be tech savvy and ask questions, but there are really different attitudes about health care. We can predict that with less health knowledge, there's going to be less management of one's illness by the person, and therefore a worse outcome. So we want to understand, does our elderly patient really understand us? Are we communicating with them? There may be problems with the elderly in hearing. They may not respond, they may nod, but they really may not hear or understand. that. There's some vision problems there. We have to be aware of the cognitive problems. With age, there can be some cognitive problems which may be mild to more severe, impairing their understanding of what we recommend. Then the other thing is to avoid elder speak unless it's necessary. Elder speak is where you speak very slowly but very loudly to a person, and that unfortunately this may occur. You may be speaking to a 90-year-old retired professor that's got it. Is very clear about things. So we want to judge our patient, and speak accordingly to them so that they can understand, but also be aware and test their understanding of what we're trying to recommend to them. Sometimes we want to involve a family, friend, caretaker, interpreter, so that we can communicate and can have an understanding, and so that they may process and have an understanding about what our findings and recommendations may be. Then the concept of ageism, which is systematic stereotyping and discrimination of people because they're old. It refers to bias, prejudice, devaluation, negative attitudes. We may write off some complaint. Well, that's just old age, or depression. Depression occurs. Old age is depressing. Get over it, live with it, and so that we can go on. So, the problem in this is that intent affects the outcome. How we perceive things, how we what our personal attitude about old age may affect how we treat the folks and how we deal with them. So we want to be able to distinguish what's normal aging from what is disease. There's a great variation in the health and functional ability when you meet those milestones 70, 80, and 90. There's a great deal of difference. I think we may see some that they retire at 60 or 65 and they kind of give up. They say, I'm old, I give up. I'm going to go to the chair and then the wheelchair, and so that's not necessarily so. Sometimes they need a little education and prompting by their physician or by others. Then those with more positive lifestyles and attitudes toward aging are more likely to lead a healthy lifestyle. They may golf, tennis, play bridge. They may be very active in taking care of themselves. In the healthcare systems, there needs to be a proper emphasis on geriatrics in training. Medical school gets pretty busy with everything, but geriatrics is important. There's manpower issues. To take care of this aging population, sometimes finding a doctor is not the easiest thing for an elderly patient. Sometimes because of the economics, some physicians limit their Medicare practice, or some even opt out. I have to get into a Medicare slot when I see my internist. He sees me, but he's not taking very many more. So there's a need for clinical practice guidelines in the elderly with chronic diseases. That the elderly metabolize things differently. They react to tests and procedures differently. So some guidelines for us to go by. Then there's the mental health issues in older adults. 20% experience some mental health concerns that may commonly be anxiety, depression, cognitive effects. The older men have the highest suicide rate of any group. And depression affects the outcome and course of treating other chronic diseases. But, there is new data that with healthy lifestyle, the brain can adapt, and people can live a happier and healthier lifestyle. So, to review strategies to improve, that with 80% of folks seeing their primary care doc at least annually, this is an opportunity to promote well-being of that. We can review test procedures for the risk and benefit of that. We want to educate about adverse medical effects, those anticholinergic drugs, the benzodiazepines, the things that may adversely affect treatment. Understand normal aging as opposed to disease, and appreciate, there's a great deal of heterogeneity of the older adults. We want to communicate with them, and if communication is difficult, to use a caretaker or a family member to address ageism, attitudes, and to be advocates for healthy living. These health inequalities not only affect individuals or specific populations, but also impact the overall health status and health care costs affecting our nations.
That was Dr. Paul H. Wick, immediate past chair of the AMA Senior Physicians Section. I'm Todd Unger, and this is Moving Medicine, a podcast by the American Medical Association. Be sure to check out the other episodes in this 3-part series about improving health outcomes for vulnerable patient populations. To attend live presentations like Dr. Wick's, visit ama-assn.org/movingmedicine to become an AMA member and register for our annual meetings. You can also subscribe to Moving Medicine and other great AMA podcasts on iTunes or visit ama-assn.org/podcasts. Thank you for listening.